Well, hi, everybody. As you get led into the room for this next webinar, the Mirus Australia webinar on quality transformation and star ratings, another webinar in the series of webinars that we've been doing for over 12 months now. Every month we try to bring you a topic that you think is relevant. So you'll all be able to access the chat. And we hope that you provide lots of feedback for us in the chat, ask lots of questions. We've got people monitoring the chat today to answer some questions if you have them, but also talk to each other. Please make sure to remember when you're using the chat to select everyone, not just the panelists, so that everybody can see your questions and your comments. That would be much appreciated. But before we begin, I'd like to acknowledge the traditional custodians of the land on which we gather today and pay my respects to their elders past and present. Where we are today, that is the Gadigal people of the Eora Nation. But I'd also like to acknowledge the elders past and present across Australia, wherever you might be today. And I extend that respect to all and any Aboriginal and Torres Strait Islander peoples on this call. So thank you for your time today. We're going to deal with the topic quality transformation and star ratings. I just want to say from the outset that this is not training. Certainly the new quality standards are coming. The new quality indicators have already started to be collected from the 1st of April. So we are going to go over some information in this session about those, but really what we wanted to focus on today is the strategic question around quality and around the star ratings. And that really is, what are we trying to achieve with our quality indicators and our standards and the rest of our quality and compliance frameworks? Where is this going, and is it working? And star ratings particularly are another way of checking on us for compliance and quality, and to make that information very public to our consumers. So at least 2 of the 4 components of the star rating are compliance and quality directly, but arguably the consumer feedback, the consumer experience information is also an indicator of quality. So really 3 out of 4 of those elements are quality compliance related in some way. So, that's really dominating the star rating as well. So really the focus of today's session is to really think about quality transformation and star ratings at a more strategic level, and where are they going, and are they working? And so we've got a few panelists with us today. We always like to bring you the voice of some providers. Always makes it much more interesting and much more real. So we'll introduce you to those in a little bit. But one of the first things we always do in these sessions is try to bring some data to the table. We're a very data-driven organisation. We produce a lot of data for a lot of providers, and we really like to analyse that and base a lot of our discussions and a lot of our thinking processes, getting a shared understanding of what that data means. The interesting thing about this topic is really there isn't anywhere near as much data on this as there is on most other things. And even the data that is available is not easily comparable, or it's not easy to do a trend analysis on it. So it's interesting. We've got Tyler still here, as we always do, our data scientist, to talk about his perspective on the data and that sort of thing. But just a caveat straight up from the beginning that this particular topic area is nowhere near as rich in data and analytics as lots of other of the areas that we talk about. I'm not saying it's not there. There is data there. There's quarterly performance reports. There's organizations out there who track and benchmark the data, but I'm saying it's not as rich as a lot of other areas are, and so it doesn't inform us as much as other areas on what's happening and what the trends might be. So without further ado, I'll hand off to Tyler to give us some of his thoughts.
Sure. Yeah. Thanks, Andrew. And I suppose what we have in place of a lot of data is legislation and documentation from agencies like the Quality and Safety Commission. And so one of the challenges that a lot of providers have faced is how do we reconcile some of this new reform legislation with adherence to quality and compliance, where it's been made very clear that a quantum of care minutes is not a representation of good quality care, or and so what I've tried to do is sort of really align the thinking around, what is the relationship between quality and care minutes, because there is undisputably a correlation between care minutes and quality. So yeah, rather than trying to look at various data sets, because there are, as you said, many people in the aged care sector, and those looking at the sector that want to understand the current state of the industry in terms of its quality, and is it better or worse than before. Ultimately, the data available is difficult to trend over time, where is quality improving or declining in aged care. There's a lot of factors that compound the problem of trying to understand that question. The measures we report and are assessed against are changing really frequently. The reliability, well, we can't trend it in any reliable way. Accreditations are 3 years apart, but a lot of facilities have extended their accreditations well beyond 3 years because of COVID. A lot of the data being collected and even the measures being used have questionable efficacy. So, well, then looking at the consumer side, the demographic being serviced has also changed dramatically. Care recipients are older, more acute, and they are starting to show that they have a higher standard of service than previous generations. And so, the quality is a perception from the consumer as well. So their perceived quality means that we're catering to a more discerning consumer. So putting all that aside, and whether we agree or not with care minutes and quality indicators and the quality standards, these are the tools that we have to measure with, and they form the rules that we need to play by. As we know, the average care minutes target for each service for each quarter is based on the service's resident case mix from the previous quarter. When this is compared to the reported worked hours in the QFR, it forms the basis for a staffing star rating for that service. But beyond a star rating, the Aged Care Quality and Safety Commission will have extra powers to enforce the care minutes standards. And claim data will be provided to the Quality and Safety Commission, which they will use along with other regulatory intelligence to monitor the skill mix within services. Ongoing program of audits to monitor care minutes data reported by providers will be cross-checked with information submitted in those QFRs and against other information sources like ANAC claim data. So that will feed into their regulatory framework, and the repercussions for not fulfilling the new workforce related responsibilities will be fair and sensible, in Janet Anderson's words. So another way to phrase that is, failing to meet a care minute requirement does not equate to non-compliance. Alternatively, meeting that care minute number does not amount to compliance either. So the care minutes establish a minimum quantity of care. This responsibility is in addition to the responsibility of approved providers under the Aged Care Act to maintain an adequate number of appropriate skilled staff to ensure the care needs of care recipients are met. Residential aged care providers that do not have an appropriately skilled workforce are at risk of not meeting quality standard 7, and non-compliance there can result in regulatory action. But within that dichotomy, where we have a number of care minutes and a staff skill mix and an appropriate level of skill, there is still the capacity to create a unique model of care, and that comes from understanding at a facility level all of the factors that go into that. And so how you choose to align your staff skill mix and resident case mix to remain compliant can take on many forms. Models of care across the industry vary widely, and they can be adapted to meet availability constraints region by region, or the varying complexity of care required service by service. This means that every provider for each of its services needs to define the model of care, factoring in resource availability, competency requirements, and the general consistency or variability of the segment of the community it's servicing. And the management of subsidy in conjunction with resource demand templates must be done strategically, not only to remain compliant, but also to remain sustainable, as those are the building blocks of your revenue and costs. So with that as sort of a frame up for the rest of the discussion, we can hand over. Are we going to go to our panel now, Andrew?
No, thanks, Ty. I did, everyone who signed up or registered for this had an opportunity to respond to our poll, which I neglected to share with you guys. So just before we jump to the panel, which we will shortly, I'll just go back to these poll results. So we asked 3 questions, and the three questions, one of the questions was, do you think that star ratings are a fair representation of your quality? Now, there's a lot of subjectivity to this question, of course, but what was really, really interesting was the numbers that came out of this. So the red and the pink combined make up 38%, which is to disagree and strongly disagree. And I think that's building on what Tyler was just speaking to. That's kind of the essence of the question we're really asking today, which is, do we think that it's working? And you might have meant a lot of things by that answer, but I think that it's interesting that 40% of people aren't sure that the way it's being measured now is a fair representation of their quality. The other question was, do you think that the increased data will help the industry improve? That was, I guess, more strongly supported. At least 40% strongly agree or agree. So, I mean, I think that's telling us to some extent that there isn't a general problem with having to provide data. I guess the question is it the right data? And we have the internal capacity to manage the change to new standards. I think this is one of the critical points that are worth discussing or worth considering in the context of this topic is, 3 or 4 years ago, they brought in new standards, and that was supposed to be the standards that really framed up the industry. 4 years later, there is a reasonable number of providers that haven't received a great deal of, with COVID and with everything else that's been happening in the last 2 or 3 years, they haven't received a great deal of feedback on how they're doing against the current standards, let alone, I mean, there are several organizations that are only just receiving their first accreditation against those standards now. So now we're changing them again. And so that's a lot of work, 3 or 4 years. It took for most people to get really, really conversant and native with the language and the concepts around the current standards, and now we're changing them again. We can understand why they're changing, I guess. There's definitely a bid to get it again, take another step to being more consumer directed, and take another step to maybe looking at the broader harmonization of home care and residential aged care. But it's going to be a lot of work, and it's going to take a number of years for the new standards to settle in as well. So interesting results. The result on that was that a large number of people do feel that they have the internal capacity to manage the change, which is an interesting result when you consider the amount of work that might be involved, and not to mention the systems implications. So a reminder, please ask questions in the chat and discuss in the chat, because we do review all of that. Any ideas on where we should go with other topics and other areas, please also provide that. So now let's have a chat to our panel. So we've got 3 panelists along today. We've got Him from Quirindi, and Sanya from Vasey, and Nicola from Peninsula Villages up on the Central Coast. So thank you, first of all, ladies, for joining us today. It makes a huge difference to hear the voices of real people on the job and experiencing this firsthand. So we might just go we might go backwards, Nicola, and start with you. The question I've really wanted to pose to you first is, just at a very, very high level, what are your thoughts on where the entire kind of quality framework is going? What's with the changes? Do they make sense to you? And do they worry you in any way, or encourage you in any way? And do you think they're working, or they will work?
Thanks, Andrew. I think reflecting on what Tyler was saying about the lack of data, and then looking at the polls that you've done with the participants from today, and neutral comes out quite strongly. I think as an industry, we probably really don't know yet, and I think that that's reflected in potentially the neutral responses that you've got. Personally, I think anything that is the ability to be transparent in aged care, I think, is a good thing. I think it's helpful for families, and I like the opportunity to benchmark. So I think some of the opportunities we've been provided is really quite helpful. My concern, where I see an opportunity for improvement, is really with I don't know, when I'm looking at star rating information, if I'm comparing apples with apples. So things such as if we're looking at the consumer experience, we don't know whether or not the type of services that the resident is receiving, do they receive extra or additional services? Are they in a not-for-profit, a private facility, which can make a difference, I believe, on the consumer experiences. Other areas such as workforce, we want to attain the benchmarked hours. There just aren't the people out there, and I think for organisations that are regional and remote struggle even more. So where it's a really difficult thing sometimes to compare yourself to somebody else when you don't necessarily have that benchmark. Then there's the other aspect around your resident acuity. We don't really know what the resident mix is, and from a case mix point of view, from facility to facility, and that can have a big impact, I believe, on some of the star rating data.
Yeah, really interesting points there about comparability of facility to facility, organisation to organisation, additional services, quality of the organisation, but quality is being given one yardstick, or certainly consumer experience is. That really interesting. Thanks for that. Sanya, do you want to go next?
Same question. Sure. Thanks, Andrew. So thanks for inviting us to the panel. Thanks for this opportunity, and thank you for your ongoing support, because having Mirus help us with the transitioning has done a great deal, and it has helped us understand a bit more as to what was required in terms of the strategy, and what was required in terms of perhaps reviewing the systems and processes and making sure that they all talk to each other, so to ensure that we get desired results. For us, it's more about, recruiting and rostering, like Nicola was saying right now. Seeing that we are compliant with the care minutes, and seeing that we have that 24-hour sort of RN compliance in the care minutes, what we have found is that similarly, like with the residents, staff are adopting approach of try before you buy. So they might be coming on board, but they might not be wanting to commit to 5 days a week, as in full time, they might want to sort of come on board for a few days and let's sort of say have the other few days with another aged care provider. So rostering and recruitment is something that we are extensively working on, and a bit more on crystallizing and establishing who's doing what, and how do we manage the rosters. We have IT changes and changes to software to sort of see where we are right now and what is it that we need to put in place. We particularly focused on the quality indicators, because quality indicators with current ratings are varying between the sites, and in some instances they're even worsening. So for us, we have found that the focus has to be on collection of the, let's say, weight measures or falls or impact on accuracy that they might have. And also we are seeing the challenge where we've got memory support units. The nature of reporting on restrictive practices makes it hard to reach those 5 stars. In terms of compliance, we are doing great there. But in terms of the resident feedback, we have tried to put a bit of a more of a consumer engagement forum and plan so for the gathering of the feedback and survey to the board and resident engagement.
And so do you think the quality measures that you just stated, do you think that is a fair representation of your quality?
Not at all. Not at all. It's a work in progress and requires continuous management. It requires a governance framework, and it requires continuous management and tracking.
Yeah, I think that's one of the things that's changed significantly is most of this indicator information, compliance information, was really judging you. I mean, so the compliance information was available if you messed up, that was made public, but you know, but now the information, the way it's being published in the star ratings is directly comparing you to other organizations on that data much more transparently and much more directly than it ever has before. So it means, you know, it really calls into question how you're measuring that information and how conservative or liberal you're being with your interpretation of what should be reported and what shouldn't be reported. And yeah, it's making a lot of people think twice. A lot of people we're speaking to reconsider how they've been approaching the whole thing. Kim, what about you? And on the strategic question of where is the whole thing going, and do you think it's representing quality well enough at the moment?
Thank you, Andrew. Look, I think given that I'm new to the aged care sector, I'm probably a little bit behind the ball, but in terms of where it's going, I don't think we know where this is going. And that's one of the things that, you know, we struggle with strategically here. I'm, you know, the leader of a small team, and there is, you know, we have a lack of resources in terms of how do we implement all of these new changes. But one of the things I struggle with is that they really haven't let us have time to embed any of the new quality standards that they want us to do before we get faced with the whole new accreditation standards. So it's just like it's this rolling ball that from a strategic level, I have to keep, you know, telling my staff everything's okay, we'll get there, we have a process in place. Whereas the fast-paced nature of the change since I've been in the industry for 12 months has meant that as a leadership team, we don't have time to stop and think, how are we going? Where are we going to go? How are we going to get there? Are we in fact getting where we want to be before the next change is put upon us? So is it working? From my point of view, yes, we have an organisation here that provides a high standard of care. We currently are, you know, are rated as 3 stars. I'm not so sure that that reflects the quality of care that we provide. We recently passed our accreditation with no unmets, but we're 3 stars in compliance. So that, because there were periods of time where we weren't compliant. So the whole thing, I think, has a punitive nature to it. And strategically, if we're thinking about how we can improve processes and how we can improve quality, then it has to not come from a punitive point of view. It has to come from more a positive point of view of, look, this is what you're doing well. Let's promote that while we work on the things that we're not doing so well. And that means that from a consumer point of view, they're also not looking at this industry from a punitive point of view. We're all coming at this from a positive point of view. And I think that's what the Aged Care Royal Commission seeks to do, is look at here's where we need to improve. But yet the Commission is still looking at this from a punitive point of view in terms of, well, let's just talk about what you're not doing well. Instead of saying, let's talk about what you are doing well and let us have time to pick up the pieces and pick up where we're not doing well, but time to embed something, you know, not just lurch on to the next thing and not let us have time to think about from a strategic point of view, from a clinical governance point of view. We've got a good framework in place, but what we haven't had time is to think about, well, how are we going to embed this before we move on to the next thing? And I think that's the risk that the Commission is facing with small providers, but probably with big providers as well, is that they haven't given us time. And they haven't given the process time to work. And that's where Tyler's point about the quality of the data will come into fact, because they haven't given us time to make good data, to submit good data. And then that's what they're basing the next step on. And I really don't think they've even told us where the end is. And that's the from a strategic point of view and from a general manager point of view, I'm thinking, well, what is the next thing that I'm going to have to ask my team to do? And how are we going to do that? And how do I keep their focus? And how do I stop change overload? You know, we all get weary. Whereas if they just slowed it down a little bit, and I know there's a political, you know, and a impetus here to get it all done quickly, but if they just slowed the pace down, then from a provider point of view, we wouldn't have such burnout at a strategic and a sort of operational level. Never mind what's happening with our staff on the floor.
Yeah, and I think you highlighted a number of things there. There's so many things going on at the same time, isn't there? There's the Royal Commission. I mean, to the extent that was holistic, it certainly uncovered a lot of issues and a lot of perspectives. There's a reaction to that to a certain extent. There's a change of government, so you've got, you know, differing agendas there. That's all sort of coming in. You've got this, trying to synchronize or trying to harmonize the different, you know, CHSP through to home care, through to residential aged care. So that whole pathway to a certain extent, and think bigger picture about how these standards sort of govern all of that, all of those levels of care. There's health, the whole health part of it, the health side of it, the hospital side of it, the GP side of it. There's so many agendas, so many things happening at the same time. I do take your point that you know, where is it going next is almost as important as where are we now and where have we come from. And I guess we're all just waiting to see what that's going to look like. But I do also agree with you that there seems to be some sort of a greater drive. I don't know if people have been in the industry a lot longer than I have, concede this as well, but there seems to be a real drive to getting this done. I agree that we used to talk about things for a lot longer. Now there's this real intent to sort of push things in quickly. I mean, you've got quality indicators going in almost on the back of ANAC, and then new standards coming in on top of that. So there's a lot of back-to-back change, which is really, really challenging. All right. So one of the things we love to do in these webinars is provide some information to take away. So we're just going to throw over to Taryn, one of our consultants and physios, who's just going to go through some of the information that we've prepared, just some things to think about, to take away. Now, some of you might be ahead of this, which is good, and some of you might not be ahead of this, which will give you some food for thought. But let's just talk about that, and then we'll kind of come back to the panel and have a little bit more of a practical conversation about what they're doing to really cope with this change and get on with stuff now, and what are they doing about that.
Thanks, Andrew. That's That's a great conversation so far from the three panelists, and to fill in a couple of gaps here and there and then move towards the future a little bit, I'll talk about that now. So the reform timeline that you can see on the screen there, as an industry, we've been working towards implementing the recommendations that have been identified in the Royal Commission, as we said, with the aim to improve our system as a whole and improving the well-being of the older people in our care as well. We've seen that change in the funding model implemented, the expansion of the quality indicators that took effect from April this month. And the work has also started on developing a new overarching Aged Care Act and the detailed draft of the revised quality standards. That was published on the 14th of October last year. So in terms of where we are now, currently, we should have systems and processes in place to start capturing that data required to meet the additional quality indicators that came into effect. The expansion requires providers to embed additional tools, which includes things like Barkle Index of ADL's activities of daily living and the Ghent Global Incontinence Associated Dermatitis Categorization Tool, big name, I know. Along with things like the quality of care experience, aged care consumers tool, and then also the quality of life aged care consumers tool. So new tools that we have been sort of exposed to before, but not necessarily to the degree that we will be required to use them now. The revised quality standards pilot is also due to commence this month, with 5 services that we're aware of commencing the pilot this month and beginning the implementation of these revised quality standards framework. And in May, we can expect another 35 services to join the pilot as well, to ensure a diverse range of provider services, the types, the sizes, the locations, and people that form part of the pilot program. So it is expected that the program will conclude in August this year, with feedback and evaluation taking place between July and September this year. So to take a bit of a closer look at the quality indicators, if we move to the next slide, you'll see a bit of the strategies that I'll talk through as well. To recap a little bit though, we've got an additional 6 quality standards now, and providers need to start capturing data from this month onwards. On activities of daily living, on incontinence care, hospitalizations, workforce, consumer experience, and quality of life surveys. And the additional tools that will be required to start planning and embedding that into the organizations themselves, that'll need to consider workforce training, available resources, the accuracy and the timeliness, among other considerations. So providers also need to sort of look at how and when they'll be incorporating the measurement tools into their governance frameworks. So what should we be doing? I would look at the future a little bit. Organizations should be commencing proactive training programs to ensure that the workforce is equipped with the necessary skills to collect and record accurate data. Now, that could involve training sessions for staff on how to use the new data collection tools, and how to accurately document the data within your data collection systems. That in itself brings a whole host of other interventions that might be required as well. So the new quality indicators will require new processes to be brought into place to ensure data is collected and recorded accurately. These processes should be embedded ideally into the organization's governance framework to ensure consistency and the accuracy in the data collection itself. The other side of it is that providers need to be testing and aligning their systems to ensure that they're accurately collecting and reporting that data as well. So that could look at updating existing systems, or a consideration of implementing new ones if there isn't something suitable out there already. That when you start looking at testing and aligning your systems, you're also going to start looking at providers evaluating vendors to ensure that the systems that you are utilizing are fit for purpose and meet the current and the future needs of the organization, future being the key part there. So that could involve comparing features and the functionality with the different vendors and their systems to determine which one best meets the needs of the organization. There's also the part of identifying opportunities to improve efficiencies in the data collection and the analysis and the processes that we have. So that could mean streamlining processes, that could be automating data collection where possible as well, and using data analytics to identify areas of improvement. And once you embed these processes into your systems, providers should evaluate its effectiveness in collecting and reporting the data. So that could involve monitoring the accuracy and the completeness of the data collected, identifying any gaps in the data, and making adjustments to the systems as needed as well. Overall, providers should be determining how they'll use the data collected to improve care outcomes. So this could involve looking at data analytics, as I said, for identifying areas of improvement, developing new quality improvement initiatives based on the data that's collected, and using that data to track progress and make ongoing improvements. So by using that data to inform the decision-making, providers can ensure that they are providing the best possible care to the consumers, which is what we're here for at the end of the day. Don't forget that the first report on these new quality measures is due on the 21st of July. So if you haven't already started, now is the time to start collecting that data. Now, if we look at the revised quality standards now as well, you can see on the next page a bit of an infographic of what it's going to look like in the future. The current quality standards have only been in effect since 2019 as part of the recommendations from the Royal Commission, though a revised set of quality standards have been developed to work towards improved outcomes for consumers. So the revised quality standards were published on the 14th of October, as I said, last year, and they build on the current quality standards, but they also include some new concepts which are new to the industry as a whole. You can see from that picture there as well, it includes the person at the center, of course, and then the organization, the care and the services, and the environment as 2, 3, and 4. 5, 6, and 7 are the optional ones that apply to some providers only. That's clinical care, food and nutrition, and the residential community itself there as well. So the revised standards are designed to be easier for the providers and the consumers to understand and implement, and they're measured through 141 actions across these 7 standards. So as I mentioned before, it's in the currently in the pilot phase. However, some things the organizations could be doing are listed on that screen there. So introducing training programs, as I said before, to get your workforce upskilled, and introducing new concepts to their skill set, such as trauma-aware care, which is a big focus in these new standards, revised standards, I should say. Start planning as well as part of these quality standards, the revised quality standards. Consumers should be involved in the strategic decision-making. So starting to build this into your processes now will support the compliance down the track, and supporting your plans for continuous improvement as well. Workforce culture is such an important consideration too. We need to consider that there's been a lot of change in the industry, as we were talking before as well, over the last several years. So bringing your workforce along the journey of change and keeping them motivated will be key. That could be done through the training itself, but also other measures that you might consider based on your individual circumstances. Don't forget to consider your systems, of course, as well. It's a big focus, and part of this new improvement is around information transparency, considering what systems you have and are they working towards integrating access to My Health records, which will assist in preparedness for this transition. It's specifically called out in the revised standards. Human resources wise, I'm sure this topic could be discussed at length. However, let's summarize a little bit and consider what strategies and systems does your organization have in place now and will need in future to manage recruitment, skills mix, retention, and contingency workforce as well. And remember, underpinning the revised standards is the person itself in the middle. So the organizations will need to think about how and when they'll engage consumer representation into the organizational planning. And this is really important because this will demonstrate effective consumer-driven care. Now, to round out Tyler and Andrew's points earlier and the panel's points earlier about the data and the lack thereof, let's unpack a little bit on the bigger picture side of things. We have the National Aged Care Strategy, data strategy, that we'll talk about on the next little page there. So we know that now the government is investing $100 million in transparency to enable older Australians and their families to have visibility over providers' performance and allow them to make informed decisions about what provider and which provider is most suitable to deliver their requirements of care. So part of this improvement includes this strategy, which will provide a robust information system to support better health and wellbeing for the older Australians. And the overall overarching data strategy is available on the Department of Health and Aged Care's website if you want to learn a bit more. But the key data capture will be reported by providers through the mandatory reporting requirements that we've been talking about, the SIRS, the quality indicators, the QFRs, along with the compliance outcomes and the complaints data as well. The strategy acknowledges that data is the backbone of evidence-based planning, so that can be used to inform policy development and help us monitor, understand, and support future planning, while also allowing us to evaluate the impact of the programs and their expected outcomes. We're still in early stages of this strategy timeline. It's from the 2022 to 2025 period. So it's fair to say that we need to allow some time for the results to be fully understood on all this data. And Andrew, perhaps back to you to discuss a little bit more on this.
Thanks, Taryn. Thanks very much. Yeah, some really interesting thoughts there. One of the points I wanted to highlight was the idea that all of this data starts being collected, these extra quality indicators. What can you as an organization do with that data? That's the other side of it. Certainly, there's a reason for reporting it, and there will be benchmarking and all of that sort of thing, but it's also a whole bunch of data that you're collecting on yourself. So what does it tell you? Certainly some of those things will lead to some continuous improvement, and some of those things don't lead to continuous improvement because there's 100 different reasons that data might not be valid or might be a once-off. So what can you do about using that data yourself is certainly something that some organizations are starting to turn their minds to, as well as how to collect that data more efficiently, so it's less of a burden on the organization. So let's go back to our panel and let's get practical. Where to from here for your organizations? What are you going to be focusing on in the next few months, 6 months, to prepare your organizations? Where are you up to now, do you think, and what do you think is going to be most important? What are you going to focus on next? Kim, let's go with you first.
Oh, ghost Andrew, what are we going to focus on first? So I think the main focus that we've been doing since I've been here is really about how do we bring our staff along. So we need our staff and our employees are the most important part of our organisation. So we've been doing a lot of work building, looking at our employee values proposition and getting that sort of embedded to make sure that our staff realise how essential they are to Quirindi Care Services and for us providing quality care. So that's always going to be a work in progress. We're also looking at how we can look at our skill mix and how can we increase the skills of our staff to ensure that, because we are a small team, how do we upskill our staff to make sure that we have more than one group who are able to collect the data, provide the care, in order that if one group of staff fall over, we've got other people there who can come along and pick up the pace and keep providing quality care, keep collecting the data, keep reviewing the data. We've also changed the way that we collect our data. So we've gone over to a different quality and compliance data collection platform, which allows us to better track our data. So, we can better run reports, we can better integrate that into our continuous improvement plan. We've also started work on collecting the new quality indicators. So we've built all of those, especially around the IAD. How do we collect that data? How do we make sure our staff are able to recognise incontinence associated dermatitis? how do they know the different levels, and where do they report that in an easy manner? You know, I've been a nurse for a long time, and one of the things that we know about nurses is that we've got to say to them, oh my God, there's going to be a fire alarm test. What's in it for me? So how do we make our staff know that we're trying to make the process easy for them? We're also trying to share the burden. So maybe, you know, some of the new data collection, we have to look at how the small management team can get involved in collecting that data. So we're having lots of think tank meetings around that. You know, nothing's off the table around how we can collect this data. I think that when we look at the Bartels, you know, one of the things that we're struggling with is that is not the most appropriate tool to be using in a residential aged care facility where we have purposely not had any stairs put into the building. So at this stage, we are looking at some of the things we have embedded. So certainly we've put those new quality indicators where we can put them into our incident forms as a way to track and measure very, very quickly. We've done that. The interviews, we have started to do some, what should we say, we're just sort of play acting around how we're going to collect those data and does it work before we go out and do it. We've recently tried to reach out to our resident community and also our families community to provide feedback on where we're up to now. There is a lack, I just saw somebody go up in the chat say something about family burnout against being over-surveyed. I think we risk that now, especially when, you know, we have to also, as part of clinical governance, have a community advisory board. So how are we going to do that? And can we use that board or the community advisory committee to provide us with some of the work that we need to do to collect the data to feed into the new standards? So it is a huge body of work that we're undertaking at the moment, but I am hoping that because we have been so open and honest with our staff and we have tried to engage them, that we will have a soft landing, Andrew. But it will be that I think that we're a small organisation, so we know that we have to stay fluid. We have to try something. If it doesn't work, we have to try something else. And we have to be flexible, and we can't say this is the way we're doing it and it not work. We have to be very, very quick to say this is not going to work. We'll have another think and we'll move on to some other way. We have put ourselves up to be a pilot site for the new standards because as a small organisation with, you know, in a rural community, then our access to support is limited. So by putting ourselves up as a pilot site, we hope that we will be successful, and that way then we can be a little bit ahead of the game. So that will be another huge body of work if we're successful, but I think it's an important body of work that we've set ourselves up to engage in. And then I think it's just about me being the driver of the bus, maintaining that positivity, maintaining the drive to always move forward, but also make sure that I bring everybody along on the journey. And it remains to be seen how successful we are, but I think we've got a plan, and if we stick to it, but we have flexibility and we have our eyes on the prize, which is really about the residents in this facility, and if we keep that as our focus, then hopefully the rest will just fall into line. And I hope I'm not looking through rose-coloured glasses, but that's the way I'm looking at it. I think that's
the only way to survive, Kim. You've got to be an optimist. Thank you for those. Thank you for those thoughts. There's a lot of a lot of good plans there. A lot to do. Sanya, what about you? I know you went through a couple of things in your opening remarks about what you were doing, but anything you'd like to add to that?
Yeah, absolutely. So we were seeking ideas on collections, including incorporating those into care plan evaluation, noting that the collection is required 3 monthly. So we've developed a bit of a support team, making the use of our volunteers, the use of our lifestyle and the quality team. So we've had a bit of an escalation process. And like Kim said, our concern was with Battelle, with the requirement regarding the stairs. And also we've noted the manual wasn't very user-friendly because in first instance did not explain whether it involved respites as well as permanent residents. So our GM of quality and risk had reached out to the department and to clarify this, and in fact, respites are included. So we've focused on providing recommendation to our staff seeking a bit of evidence in terms of best practice, so matters to consider, and also focusing on risk-based questions. So we've developed a bit of a task force, if you will, to review our clinical assessments. And that's to aim and reduce the workload on staff and compare the data to avoid double handling of the information, and particularly review of the monthly indicators as well. So we've got some resources and some time set up to train staff in terms of the 2 new assessments, so Bartel and Globe 8, as well as the 2 new experience surveys. So that's the plan, to sort of focus on those 4 elements and provide appropriate staff training and resources that can help staff on their way to understand as to what the expectations are and what are the particulars that we are looking into collecting. So our plan is for the assessments to be, as we know, they must be completed on every resident every quarter. But additionally, all of our residents will be offered the opportunity to complete the quality of care, aged care consumer, and quality of life sort of surveys. So we will be focusing on that and see what it leads us to.
Oops. Thank you, Sanya. Thank you. Yeah, good detail in there about how you're approaching some of the specific indicators. So I appreciate that. I'm sure people listening do as well. Nicola, you can round us out with your thoughts on what are you going to focus on first? What are you going to do?
We don't really know what star ratings will be used for. So I think strategically where I'm at leading quality within the organisation, it's trying to optimise them as much as possible, just because we don't know what they will be in the future. So looking at the different areas within the NQI data collection, I'm really excited to have a look at the quality of life and how that comes through. The consumer experience, we've already been collecting that ourselves, but touching on what Kim said, it's very much around training staff for identifying the areas within the data that you're collecting. But it's very different saying, oh, you didn't like your lunch today, ticking it off, whereas how do you find the food here? So there really needs to be a training component for your staff around that. And I'm really keen to have a look at an industry level what will be done to ensure there's some consistency around data collection, because otherwise we're not playing on a fair platform. So I'm really interested to see what happens with that. We're working as well with our care software provider to really try and automate the data collection as much as we can, because there is quite a lot of it's quite a burden as such if you were to do it manually. So we're looking at automation where we can. For the consumer experience surveys, we've written to all of our families and our residents and reminded them of our feedback process. We don't want them to necessarily wait for that to give us a rating, where we could have worked with them early to improve their feelings around an area. I'm also including it in orientation. I deliver a session on values. So because a lot of the answers, the questions are around values, we're touching on that, as well as monthly training to our staff around areas for respect and how it links back to both the code of conduct and our own values that are for our organisation. With the care minutes, we have a really robust workforce plan. We are like a lot of people, we will sponsor overseas workers. I'd love to see the ability to sponsor care workers under a business sponsor be able to be approved. That would make things a lot easier for us than having to go down a labour stream. So I'm really keen to see what happens in that area, because that will really help us try to attain the minutes. It's just the pool's not very deep for applicants out there. I think we're all finding the same thing. And I guess I see compliance really just trying to bring it all together. So where the standards come in, all of the areas that we've spoken about, compliance is really that one area that we see all of the different aspects that we work around come together. So that's kind of the framework, I suppose, that we're moving forward with at the moment.
Yeah, thanks again, Nicola. Some really good good thoughts there on how to just get on with it and get practical. And I think it was back with Kim when you were talking about the employee engagement and the role of resources in delivering quality care and how important that is. And I think with all the resourcing industry issues in the industry, I think and across health generally, I think it is a really important aspect of it. I think just to touch on some of the comments in the chat, somebody raised a question about star ratings and you know, what is it going to be used for? Is anyone, you know, no one's really raised the star ratings to them as a consumer or prospective consumer yet. I think definitely the jury's out on whether the star ratings as a consumer index will make any difference to people, how they choose facilities. I guess they will in some cases, but will it affect your occupancy significantly? Who knows? We'll have to wait and see on that. But I think the other interesting aspect about the star ratings, and the reason we include it in forums like this and around the strategic questions like this, is it is a framework. It is an algorithm. It is a framework that's been developed to really to calculate the relativity of one provider over another provider as best they can. So what we see as being important for that is that a lot of the measures that the Quality and Safety Commission have, you know, care minutes, for example, you met them or you didn't met them. Well, there's another graduation of that, and that is down to the care minutes that are treated in the matrix of RN minutes and overall care minutes in the star rating, and then they can use that as another way of filtering out which providers they want to look at first and which providers they don't. And the same with the quality indicators and the quintiles. So that quintile analysis in the star ratings is also stratifying everybody. And again, really good comments earlier on about comparing apples with apples, and is that fair? And some of those indicators we talked about just now, are they the right ones? Will they change? Will they be replaced by others? I know some of them are so coarse that, you know, the difference between having one event and not having an event could put you, you know, it could move you several quintiles, not just one. So some of them may not be fit for purpose for data collection going forward. It'd be interesting to see what happens with that. But definitely the star ratings as a framework is being used as a way of helping the Quality and Safety Commission to target the underperforming providers in their eyes. There's also lots of comments about resourcing, lots of comments about fatigue in the chat as well. So I think in the interest of time, Taryn, is there anything else significant that you think came up in that chat that you wanted to highlight?
Yeah, thanks, Andrew. In the interest of time, I think the most popular question, given we've all sort of talked about it to some extent, was the consistency of the data collection and what tools you're using to get that collection done. Quality data broadly, what your services are using. Everyone's interested to hear about each of your perspectives. Yeah.
It's Kim here. So we have recently gone over to a platform called Comply Space, and the reason I like that is because we're able to adjust that to suit our needs. So if there's not a data collection tool in there, or a form, or a process, then we can amend it. But it's the quality of the reports that it puts out for us. We've had to put some new processes in place around how we capture when residents leave the facility in order to go to the emergency department or a hospital. I must admit that's the new quality indicator that I'm most worried about. What are they going to do with that data, and how are they going to use that data to reflect back on how that impacts on the quality of care we provide, when largely that's outside our ability to influence. And I guess we've looked at whether we need to buy more laptops in order to make the data collection process easier, or tablets. A lot of our data collection is already built into LeadCare, which is the clinical framework that we use. So I think it's just been about amending what we have instead of trying to reinvent the wheel.
Thanks, Kim. Nicola, Sanya, do you have any recommendations or anything on what you use?
We actually use a bespoke system that was developed by a previous employee. I actually feel that it's really robust. We've just gone through our accreditation after not being assessed for 5 years, so under the new standards. And we've got 3 years with no unmets. And then we use Management Advantage, so Manad as our care software, and that's who we're working with at the moment to try and automate some of the NQI data.
Thanks, Nicola. Sanya?
So we are in process of changing the software. So we are going through the validation process of doing the walkthrough and seeing what we got at the moment and what we need to put in place to help us on our way collecting data. So we are still in the stage of exploring and determining to see what would work for us best.
Okay, thanks, Sanya. So just a couple of ads from us that are relevant to this subject. If you do need help with your quality information and indicators, we can provide help in this area. One of the things we wanted to highlight, though, is that we do have a free star ratings analysis report. It will help you understand your star ratings data better. It's just the star ratings data is just about to be publicly updated, as you know, for the most recent quarterly round of data, and we can update those reports and have that conversation with you to help you make more sense of that. If you want to know where to go with that information next, and that's free. We do offer a number of quality and compliance support services, so please contact us if you want to know more about that, including in the middle there, standards training. So the standards training is both training on current standards and the new standards. So it does a comparison between the two. And you can also start planning and doing workshops to work out how you're going to change your organization. Great points there from everybody about how you can use systems to manage your data. The next webinar, please join us, is going to focus on care minutes and the quarterly financial report. So it'll go in, it'll be timed to be just after the next quarterly financial report goes in. So it'll be fresh for all of you. But what we really want to focus on is where people are getting to with their care minutes, approaching the 1st of October when they become mandatory, what people are doing about it, and how the quarterly financial reporting process is going, and how people are finding that hard or easy. Please join us there. We'll have another panel talking about that, some more providers. So please jump on and register for that early and join us at our next webinar. And please, in the chat, let us know any other topics, subject areas that you're really interested in, because we can set the topic of these monthly webinars to another topic. That's it from us. Thanks, a couple of minutes over. Thanks for joining us again. Thanks so much to Kim and Sanya and Nicola for giving us their time. Really appreciate it. Makes such a difference to hear real people talk about what they're doing, and we really appreciate it. And everybody else who took the hour out to spend with us, thank you so much, and we'll see you next time.